Yeah, can initiate. Aravind, Jaswant, one of you start discussing.
Okay, let me just show the case.
Yes.
Okay, is it visible, the slides?
Yes,
Yeah,
sir,
yeah.
visible.
Okay.
Yes, sir, visible.
Okay, we can read out. The first person, Jaswant.
Yes, sir. Mr. A, age
Keep your video on if possible.
Okay. Mr. A, 50 years, hailing from Thrissur, occupation, manual laborer, presenting complaints are difficulty in swallowing for since 3 months, loss of weight since 3 months, about 20 kgs, with loss of appetite since 3 months. 50-year-old man presented with history of difficulty in swallowing for 3 months duration, which is insidious in onset, gradual in progression, initially to solids in the form of sticky sensation of food for first 3 months, then gradually progressed to semi-solids for the past 2 months duration. Now he is able to swallow only liquids with mild difficulty.
Okay, now this is the gist of the case. This is what we have, the patient has told and what we have elicited. Now there are, we want to know more details. What are the details you will ask in such a situation? And what is the relevance of each of your question?
Before that, can I just intervene? I've told this several times, no, that loss of weight and appetite cannot start along with dysphagia, okay? Just be very sure about this. Patient, in fact, will feel like eating, but he'll not be able to eat because of difficulty in swallowing. So loss of weight and appetite will come on much, much later. So don't bring all the three together as 3 months. This I've already said.
That's a very valid point.
Yeah, wider the lumen. If you have a CA stomach or a CA colon, then the weight loss and all may proceed and symptoms may come on much later. But in a patient with difficulty in swallowing, they'll feel like eating, but they cannot eat. So the loss of weight and appetite will come on much, much, much later. So do not bring all the three together. Never, ever bring the three together.
Okay, in CA esophagus, this is the pattern, but in CA stomach, they may have anorexia, probably a little earlier than what is they expect in CA esophagus. Okay, now just one, what are the negative questions you will ask?
Negative question, sir.
I mean, this is what the positive history we got. Now we want to elicit further to get more details. So what are the additional things you ask for?
Any history of vomiting, sir?
Why do you want to know that?
Because there is difficulty
Each
in
of this
swallowing,
question
you have to
has to be relevant to the case. Okay, when
means
you
what is the means how much time, if there is a dysphagia, there is initially to the solids followed by there is a liquids. So any pathology in the esophagus or in the stomach, any pathology in the esophagus, you will have immediate vomiting, sir, if there is any solid phase dysphagia.
Okay, but very often that is not very relevant. Lesions in the GE junction, perhaps they may vomit immediately after food intake, but mostly it is dysphagia and sometimes only when they get sort of some impaction and all, vomiting and all will be a feature.
You have to
Okay.
also ask about
In another condition where you have dysphagia like achalasia cardia, it is mostly regurgitation and not vomiting. So in classic motor disorder, achalasia cardia, it is regurgitation. In GE junction lesion, perhaps there could be vomiting soon after eating. That could be a dominant symptom also, and dysphagia may be a sort of a less symptom for them. Okay, but what is other things you will ask for?
Any history of melena also we have to ask, sir.
Okay, Jaswant,
Yes.
you are Jaswant, right?
Yes, sir.
Okay, now from the available history, where do you think is the lesion? Because whenever we think of a patient, we have to decide from the history, we have to roughly locate the disease and then ask questions accordingly.
Okay, sir.
What was he telling?
There is a difficulty in swallowing, sir. For
There was one thing. Okay, because when there's a difficulty in swallowing, unless it is elaborated, we really do not know whether it is in the oropharyngeal region or it is actually whether it is in the esophageal region. Okay, but there are some points in the history, like, for example, for sensation of a sticky sensation of food in the chest.
Okay, sir.
Okay, that may perhaps make it perhaps in the esophagus. But so we have to elicit the history in such a way that we should be absolutely sure whether we are dealing with an oropharyngeal dysphagia or a esophageal dysphagia. Okay,
Okay, sir.
so Anirudh, the next person is Aravind. Yeah, Aravind, sorry. Aravind, what all additional
Yes,
questions
sir.
you will ask?
Sir, we should ask if there is any history of nasal regurgitation or while swallowing, if there's any difficulty in while swallowing the food, if there's any nasal regurgitation or cough associated with
Okay,
swallowing of food.
why
Sir.
do you want to know? Why do you want to know this?
Because this can be due to oropharyngeal dysphagia. These symptoms can occur in patients who have oropharyngeal dysphagia, sir.
Okay, will all the patients with oropharyngeal dysphagia will have this symptom? Like nasal
No, sir. Depending on
regurgitation
the
and cough on
etiology.
attempted swallowing?
No, sir. If there is a neurological involvement, the
Okay,
soft palate is not
neuromuscular,
functioning
not only
properly.
neurological, neuromuscular. So if there's a neuromuscular problem during the swallowing process, if there's a neuromuscular deficit disorder, you may get a history like a nasal regurgitation. Why do they get nasal regurgitation? What's the pathophysiology behind that?
The soft palate will not get opposed to the pharyngeal wall, sir. If there is a
What is the reason for cough on attempted swallowing?
When laryngeal muscles are not functioning properly, when the larynx is not closed on swallowing, you can develop
Larynx
cough.
lift up and epiglottis closes it, and then only the food passes down to the trichopharynx and esophagus. So the laryngeal inlet will be kept open due to the weakness of laryngeal muscles, and that will lead to tracheal aspiration. Is there any situation where the laryngeal muscles are intact, but still patient can get cough on attempted swallowing? Is there any other situation?
Sir, if the patient has
Laryngeal
diverticulum,
muscles are all intact.
If a patient has diverticulum, they can aspirate, sir, even in presence of cricopharyngeal.
Okay, that's a Sanger's diverticulum. They may periodically have this problem, but classically it is in a tracheoesophageal fistula. Tracheoesophageal fistula also you can have cough on attempted swallowing. Okay. Now I will show you a list of negatives which the person who has prepared the case has done it in a very elaborate fashion. Okay. See that. There's no history of difficulty in initiation of the swallowing. This actually helps us to find whether there is a oropharyngeal. No history of choking, nasal regurgitation, which was covered, cough, change in tone of voice. Why do you want to know that? Because a patient with a recurrent vagus involvement may have hoarseness of voice. Then drooling of saliva actually means paralysis of other muscle, deviation of the angle of mouth or suggest perhaps other muscles covering the mouth and other things like a fifth nerve and ninth nerve, 10th nerve, 12th nerve. So many nerves may get affected. Okay, what is the relevance of weakness of limbs and all? Weakness of limbs, weakening of eyelids, tremor, gait, etc.
Myasthenia gravis, sir.
Myasthenia.
Yes, sir. Myasthenia gravis.
Okay. Okay, so a large variety of muscular disease, myeneural junction, neural disease, low motor neuron lesions, lesions of the spinal cord, especially the medulla, then the central nervous system. All this can actually produce problems. So one must be aware of all these things. Okay.
The only thing is, what is the difference between mechanical obstruction versus neuromuscular or neurological disorder? They'll have difficulty in swallowing simultaneously.
Mechanical obstruction, patient will present with dysphagia more for solids, madam, initially. And then gradually it will get progressed to liquid. But in case of a motor dysphagia or a neuromuscular dysphagia, they'll have solid and liquids together on onset.
Right. Okay.
They have not mentioned painful swallowing. What's the relevance of painful swallowing?
Painful swallowing, it can occur in conditions like pill esophagitis, sir, which is a very common cause of odynophagia. Then it can
Okay,
occur
this is
because
called
of
odynophagia. What is the most common cause of odynophagia in the community?
reflux, sir. Reflux esophagitis
I would
and
say
pill
acute
esophagitis.
pharyngitis. I would say acute pharyngitis. That is the most common, and most of us would have felt it, no? When you have severe cold, severe sore throat, that's the most common in the community. But for gastroenterologists, pill esophagitis, reflux esophagitis may be much more common. I will show the
Dr.
next.
Varghese,
Yeah,
Dr.
Yeah,
Varghese, can I
ma'am.
say something?
Yeah,
Yeah, please.
definitely. You are welcome. Most welcome. We are waiting for you.
Yes.
Please switch on your
Yes.
video, ma'am, and please help us.
Okay. No, I don't want to switch on my video right now, but the question is about odynophagia or painful swallowing. Besides pill esophagitis, sometimes candida esophagitis, viral esophagitis can give rise to the same symptoms. And in many of these patients, at least in candida, you can detect by looking at the throat. If there is candida in the throat and the patient has odynophagia or painful swallowing, we must suspect that this is due to candida.
So that means significant esophagitis, no?
Yes, significant, but mainly just gastroesophageal reflux related esophagitis rarely gives rise to odynophagia. Other causes of esophagitis like infective pill, they are the ones who will cause odynophagia or painful swallowing.
And if you consider all the causes post TST, post EVL, no, all those situations.
All those, those are definitely there. Yes,
those are there, but it is quite evident. The patient had EST or EVL, it's quite evident.
Yes.
But the ordinary patient do not come with that history, no. So thanks, ma'am, for that wonderful input.
I'm keeping on adding inputs, but I'm not keeping my
definitely
video.
You are most welcome. You are the we are happy that you are with us because you are the best person to discuss about esophagus and dysphagia. We are happy that you have joined us.
Yes, so thank you. But Dr. Jayanthi just pointed out one more thing. One is a foreign body. Now, just regarding foreign body, if the foreign body is stuck, it can cause dysphagia. But sometimes if the foreign body is stuck in the pharynx, and it's a small foreign body, the patient may not come with dysphagia, but may come with a retropharyngeal abscess after a few days. So that is to be kept in mind in these cases.
Yeah,
Jayanthi,
that's another
anything more
important.
to add?
Yeah, that's an important thing because very often we get patients referred from ENT side with fishbone stuck somewhere in the pharynx and they have severe pain and dysphagia. And of course, the patients will tell that story. But if you consider odynophagia, that's also odynophagia. No, sharp foreign body stuck somewhere in the pharynx. That will produce severe pain. And as ma'am rightly said, if it remains there for a few days, it can produce abscess. I had a patient who had an abscess in the parapharyngeal area with a fishbone, and it was producing severe dysphagia. We had to drain it.
The other one is dentures, suddenly old people and all, they don't remember a tooth has fallen. So, sometimes you don't even know that a tooth is missing. So very important is you have to just check out, at least from the relatives, whether he had a denture. All these things are common and they all can present as, most of them are acute onset, okay?
Acute onset dysphagia,
acute
dentures are very dangerous, especially nowadays. There are sets of dentures with multiple sharp points. And I had a patient, an youngster from, he had a denture, probably had a dental extraction for modification of misplaced teeth, etc. And he swallowed it during sleep and it produced perforation of the esophagus. It produced severe mediastinitis and he had to be on multiple tubes and he was in the hospital for 2 months and of course he survived just swallowing of danger. Okay, so it's a very dangerous thing, acute dysphagia. Thanks ma'am for that wonderful point. There are so many other negatives. Just look at this.
Yes, sir.
What's the relevance of this hot and cold substance?
Hot and cold.
No change in difficulty in swallowing. See, is there any hot and cold? Does it really, is there anything like that? Some patients have some problem with hot fluids or cold fluid. Actually, when it is warm, odynophagia, people feel which is a little more sensitive. But cold, I think, is for motility disorder like achalasia cardia, etc. They will feel symptoms are worse. Nocturnal cough, regurgitation, recurrent chest infection. What is it? What do you want to exclude by this question?
Any diverticulum, sir? Any diverticulum?
Okay, you have told it earlier, but I think more importantly,
Nocturnal
in a case of dysphagia, what is more relevant? Yes, Aravind.
Achalasia cardia has to be considered, sir, in case of
Yes.
nocturnal cough.
That is, they have stasis, and when they lie down,
Yes,
the stagnant food reaches the larynx and then gets into the larynx and the respiratory tree and produce cough. Sometimes it may be very severe cough. Some people, I had seen a patient presenting with lung abscess for the first time. Dysphagia was minimal. Okay, and because of the lung abscess, they took a CT and CT showed massively dilated esophagus. So such rare presentation do occur. Okay, so that is a lot of negative things we have covered. Okay. Is there any relevance for chest pain and dysphagia?
Yes, sir, there will be a common nerve supply for this thing.
Which are the situations where you get significant chest pain? Odynophagia we have already mentioned. But other than that, patient getting intense chest pain and dysphagia. Can you tell us some conditions?
What are the common causes of non-cardiac chest pain?
One is GERD, ma'am.
Okay, GERD can produce chest pain. Okay.
One is any chest pain. Perforation also can cause retrosternal chest pain, sir.
Okay, I was telling about in a patient with the dysphagia,
Motor
they have
disorders.
intermittent chest pain, which is severe.
Motor disorders.
Yeah, severe motility disorders of the esophagus, even achalasia can present with chest pain. Other types of motility disorders, esophagus also can present with chest pain. Okay. Apart from that, as you rightly mentioned, other disorders affecting the esophagus, perforation, or and mediastinal diseases, etc., can also produce chest pain. For example, if a large aneurysm or a mass lesion, etc., infiltrating the esophagus, those all can produce some degree of chest pain plus dysphagia. Okay, so we will move to the next part. Patient gives significant disturbed loss of weight of 18 kg. What is your comment on this?
There is a significant weight loss is there, sir, because as the patient is not able to take intake of food due to dysphagia, sir.
Okay, so generally when a patient has dysphagia, they will alter the type of food. Because in an esophageal dysphagia, hunger will be actually, they will be voracious. They have voracious appetite in an esophageal stricture, and they try to alter the type of food from solid to semi-solid to liquid, but they will try to keep on eat to satisfaction. But the quantity may be less and the quality also will be affected. But 18 kg of weight loss in a patient in 3 months and anorexia to begin with, your antenna should be up. Because in a straightforward esophageal carcinoma, this much weight loss within 3 months is rather unusual. So what else you will consider?
That is what I said. No, in the exam, be very careful. When you have a patient with dysphagia, just see what is the temporal relationship of the nausea, the difficulty in swallowing loss of weight and loss of appetite in relation to the symptoms. Either you make it, that over this period of time, you can just say it like that. Over this period of time, there's been a significant weight loss. Don't mention the period as 3 months. It's just not possible, okay? Mention about the progression and then say during this period of illness, intake has significantly changed and there has been a change in and there's been over this period of 3 months, there's been a significant weight loss. And towards the end, you'll have to also say whether he's able to swallow saliva. Sometimes that is stage 4, no? They cannot even swallow saliva. So what are the various classifications of dysphagia? How do you grade it? How do you grade dysphagia?
Are you aware of the grading of dysphagia? There are different types.
There are 2 types of grading, no? There are 2 types of grading. One goes 1 to 4, the other goes 4, 3, 2, 1. Can you
I think there are 3 types of grading. A Kurtz grading, a Said grading, and one more grading is there. Okay. Do you remember those?
Yes, sir. Ickart's grading,
Your voice is breaking, Aravind. Can you repeat it?
Yes, sir. Dysphagia, regurgitation, chest. These are ICART scoring, sir. The score is from 0 to 3.
Okay. So what is 0 and what is 1, 2, and 3?
Is it okay? 0 is no dysphagia. 0 is no symptoms, no dysphagia, no regurgitation, or no chest pain or weight loss. If it is 1, it is occasional. If it is 2, it is daily. And if it is 3, it is associated with every meal.
What is aphasia?
Sorry, sir.
Have you heard of aphasia?
No, sir.
Not he's not interested to.
Not interested. He is not able to swallow at all. Aphasia generally occurs mostly in neurological conditions, acute neurological conditions. Okay, it can occur after food impaction, where nothing will go down, including a drop of water, saliva, nothing will go down. Okay, but mostly it's an acute onset of severe dysphagia occurring in acute neurological conditions. So I think past history, there is nothing relevant. Okay, if a patient with dysphagia has sort of extreme weight loss, what are the things to run in your mind as a drop-on list? Extreme weight loss.
First thing will be first thing. So first thing will be malignancy, sir.
Okay, see, whenever you have a patient with a weight loss, you have to assess where the loss of weight is proportional to the reduction in the food intake. That's the most important thing. Because a GAT illness very often affects the food intake. So whether it is proportional to the reduction in food intake or whether it is out of proportion to that. Only if it is out of proportion, it can be called pathological. If somebody does not eat and they will lose weight, it is obvious. Okay, so somebody is continuing to eat but lose weight is very important. So, but still, this much 18 kilo weight loss is a little too much compared to the just 3-month duration. So when a profound weight loss in a patient with GAT illness, what are the things you should keep in mind? Can an illness produce profound weight loss and dysphagia? Just 1 or 2. You said malignancy. Okay. Advanced malignancy with extensive metastasis. Okay, it is possible. Okay.
Gastroesophageal junction tumors, esophageal.
Okay, you already told neoplasm, so we have covered it. Okay, rather than esophageal, it could be cardiac tumors, especially fundic tumors, which can put dysphagia, but so there can be anorexia to begin with. Okay. I think HIV is one condition where you think of whenever you have a patient with a marked weight loss and you are not able to explain things properly, always keep in mind HIV.
Yes,
okay,
sir.
that's one thing which will produce weight loss out of proportion to what you think clinically and then some symptoms. Can HIV produce dysphagia?
Yes, sir.
Yes, sir. Candidiasis, esophageal candidiasis.
But do you think that our patient has got that problem?
No, sir. It started with solid and it progressed to liquid.
Yeah,
so
it doesn't look
seems
like
to be a luminal pathology.
Yeah, it looks like, okay. Now I will show the next
Just
slide.
a moment, Dr. Varghese.
Yeah,
just a small comment.
Yeah.
You know, sometimes in very early dysphagia, as you rightly said, the patient may modify the diet. When they modify the diet, they actually don't notice dysphagia. So what they do is they correct all kind of maneuvers, drinking water, and they complain only after some time. So sometimes the disease, the symptom onset is 1 or 2 months before they actually complain of this. So though we are saying that the symptoms are only for 3 months, it may be for 4 or 5 months that there are mild symptoms. He may be eating slowly. He may be making some changes. And in 6 months, if a patient has lost 18 kilos, we don't feel that it is excessive weight loss.
Okay. 6 months will be, okay. That, ma'am, is there any, this maneuvering by the patients to, when they have significant dysphagia, is it common for all problems of dysphagia or is it more with the motor disorders?
That is for motor disorders, but in mechanical disorders, what they do is they avoid solid foods. They don't say that they are having dysphagia for solids, but they are avoiding, or they shift to chewing extra. So when they shift to chewing extra, they've already converted that solid to a slightly semi-solid food. So then they say, we don't have dysphagia. We just had this much problem, but that we ignored it. It went away. Nothing happened. And then when it starts progressing is when they actually notice the dysphagia. So the duration is never correct in these cases.
Jaswant,
Yes, ma'am.
Jaswant, what?
Yes.
How much of lumen should get obliterated before a patient develops dysphagia?
Less than 13 mm, ma'am.
No, that you cannot say, no. You cannot say 13 mm is when you're doing the procedure. 2/3. When 2/3 of the lumen is obliterated by a tumor, then that's the time when they start getting dysphagia. So that is why they always manifest much later. So 2/3.
Yes.
Technically, Jaswant is also correct because some of the examiners will ask exact measurement because
Yeah,
that's
so
the cutoff for
I just want,
refractory stricture, no? Anything.
I want to ask you, what is the AP diameter and the transverse diameter of the esophagus? Transverse and AP?
Is it a
This may
cylindrical
ask.
organ or is it a little oblong?
It's oblong, sir. Transverse is larger than the AP usually, sir.
AP is 2 to 3 centimeters, sir.
2 to 3 centimeters. You've never swallowed a pani puri?
What is trans?
So think about it.
You should know the exact diameter.
This
Yes.
is homework for you to read.
Okay, sir.
Okay. Then nothing significant in the past. No neurological illness. Nothing. So of course, he's a smoker. Is a smoking risk factor for CA esophagus?
Yes, sir.
So sure. Are you sure whether it's a risk factor? It is.
Yes, sir.
Not
Yes,
only
sir.
for esophageal, but for pharyngeal cancers also, it's a risk factor. Okay. So family history. Okay, he has reduced the food intake to 1,000 kilocalories now. Okay.
Can we go to the previous slide?
Yeah.
So
Just 1 second. Let me find. There's some extra noise. Aaron, please.
1 minute. The 2 packs per day is 40 cigarettes, no? How do you calculate the pack years? Jaswant?
Number of pack here.
How do you calculate now? 40
40
by 20?
packs per total number of years, ma'am.
40, 20, each pack contains 10 or 20.
20.
Actually, in India, it is 10, and in Western countries, it is 20. So actually, when we calculate in India, you have to take that into account. Okay.
Yeah.
The description was given by the Western people, and their cigarettes usually, by default, it is 20 cigarettes per packet, and it's calculated like that. Okay.
Yeah.
So you have to be careful when you calculate it. You have to be aware of this problem.
20 by 20 to 20. So it'll come as 20 pack years for Indians, but by Western standard, it'll be 40. Be very careful about that. And
Okay.
corrosive
Our
injury is
cigarettes
important.
contain less number of cigarettes.
Corrosive
In a
injury is
packet.
important, okay? Corrosive injury.
Okay. So summary. Jaswant.
50-year-old male patient with history of painless progressive dysphagia, grade 2, mainly for solids and semi-solids with associated significant weight loss without any regurgitation or chest pain or UGI bleed or recurrent chest infection, with no history of any comorbidities.
1 minute. Important negative points of cough is important. Dysphonia or change the recurrent laryngeal nerve can be involved. So you can get a change in the voice. So those two are missing here. Regurgitation is okay. Chest pain is okay. GI bleed, recurrent chest infection. Cough is important and voice change is important. And regurgitation. No?
Performance scale of 2.
So what's
So
the
how do you
syndromic?
rephrase this summary, including more relevant points?
50 years old male with
What about the anorexia is not mentioned at all. Weight
Yes,
loss is there. What about
Anorexia and
anorexia?
weight loss to be mentioned, no? Okay, you
Anorexia.
rephrase it. We have suggested
Anorexia.
many things. You rephrase it and make it a very good summary.
50 years old male with chronic smoker with presented with history of painless progressive dysphagia for the past 3 months of grade 2, initially for solids, followed by semi-solids, and now for liquids, with a significant weight loss of around 18 kgs.
Anorexia and weight loss goes together. Anorexia and weight
Anorexia
loss.
and weight loss of around 18 kgs without any history of initial difficulty in initiation of swallowing, without any features of nasoregurgital regurgitation, cough or nocturnal cough or chest pain, with a ECOG performance scale of 2.
Okay, so this is it. Now,
Smoking also has to be included, sir. Smoking
yes, already
significant.
told. Yeah, it's a chronic smoker. He started off saying by that. He's 50-year-old person with chronic smoking. So that is included. Okay. So this is what? This is the summary. Okay. Now actually you have to discuss. Now I will ask Arjun to present his case and we will discuss the remaining part afterwards. Dr. Arjun, I am stopping my slides. Dr. Arjun,
Yes,
please upload your slides.
Yes, sir.
VT,
I'm able to
let
hear.
them
I'm audible,
give
sir.
1 minute. Let them give a syndromic diagnosis. Let them discuss it. No, they have all been hearing all these. Jaswant, tell what's your syndromic diagnosis in this patient?
First possibility is a CA esophagus.
No, that's not your syndromic. No, what will you say is your syndromic? What is your syndrome in this patient? Progressive dysphagia, right?
Progressive dysphagia, more for solids. Initially for solids.
No,
That's all over. That's all
That's
over.
all
Now
over.
you have to tell a syndromic diagnosis.
Now you say syndromic diagnosis, you say progressive dysphagia.
Dysphagia.
Number one, mechanical, most probably mechanical dysphagia.
Rather than
In that, 1 minute. In that, the etiological possibilities are 1, 2, 3, 4. Okay, with comorbidity, with a significant loss of weight and anorexia is the main complication, with no comorbidity and a performance score of 2. Okay, so you'll have to mention that. That is, so it's progressive dysphagia, grade 2. Okay, and therefore it's mechanical obstruction. Would you like to consider motility, these motor disorders as a DD?
No, ma'am.
You can never say no, okay? Never say no. Never say other differential will be a motor disorder.
Okay.
Will be a motility disorder will come as a DD. Now, in the mechanical obstruction, your first DD will be a mechanical obstructions in neoplasm. We do not know whether it's a GIST tumor, whether it's adenocarcinoma or squamous cell carcinoma. We do not know. What we know is it is a mechanical obstruction. So it is a mechanical obstruction. Probably it is something in the lumen. So number one would be neoplastic lesion, which can be benign or malignant. Okay. That's how you discuss. Okay. And then number two would be, it could be an inadvertent foreign body. We never know. Number three, it is also possible there was a motor disorder on which there's a neoplastic lesion that has taken place. All these will come as your DD. Maybe it's an extrinsic compression. Okay. You're talking away, but don't keep focusing yourself on. So the lesions can be in the lumen, it can be in the wall, it can be outside the wall. Okay. So within the lumen, what all can obstruct? It can be a foreign body, right? Okay. It can be a neoplastic lesion that is infiltrating, right? So these are the two important ones that can be within the lumen. Now in the wall, it will be largely a motor disorder, or there can be in the muscular plane, you can get a leiomyoma, you can get a GIST tumor, it can be a lipoma, it can be then outside that can be any of the mediastinal pathologies, like it can be a bronchial cyst. We have seen so many types of cases, neurofibroma, it could be a retropharyngeal abscess, it could be a cold abscess. So, and it can be just a large diverticulum. Maybe the person has a huge diverticulum that is actually causing extrinsic compression, and patient is having actually mechanical dysphagia. So this is how you discuss. Then in that category, once you finish this differential, then you say motor disorders is also one possibility. But in these patients, it is often a simultaneous difficulty in swallowing solids and liquids. Weight loss can be there. Usually appetite will be retained. Okay, that appetite will be retained in most of the motor disorders. And even in early stages of CA esophagus, appetite will be retained. There will be no anorexia. It's only the weight loss that starts, and then they feel like eating, but they're unable to eat. So do not miss foreign body, do not miss dentures, do not miss inadvertent or demented patients, patients in mental hospitals, they swallow brushes. We've seen all types of foreign bodies.
Yes.
So that's how you describe the syndromic diagnosis. And then you go to the examination. Okay, so it will be progressive dysphagia, grade 2. And then my differentials are mechanical obstruction. You agree it is mechanical, no? It is mechanical. It is something is progressive. So that your first DD will be mechanical. And that will first say neoplastic, benign versus malignant. The age is such with progressive weight loss, malignancy most likely. It can be squamous cell, it can be adenocarcinoma. Then they will ask you, when all can you get adeno, when all can you get squamous? So you just giving a lead to that question. Then benign conditions would be a GIST tumor, leiomyomas. All these are moving into the lumen. And number 2 would be inadvertent foreign body. Especially, we had a patient, no, he had only 2 or 3 teeth, so I just asked him, he says, no, I'm very sure that no tooth fell off. But if they have swallowed and there's a Shatsky ring, so the person has a Shatsky ring. We've had patient with post-EST coming saying that I took banana and after that I'm not able to swallow. But these are all acute onset. They're not a weight loss. They'll come immediately to the hospital to take it out. So the syndrome, this is how we discuss the syndromic diagnosis. Okay. Okay, Shobna,
Okay.
Dr. Varghese, can I say
Yeah,
something?
ma'am, please.
Sure.
Shobna,
So
ma'am.
another thing that, when you discuss this, like Madam said, you talk of mechanical strictures, mechanical obstructions. First is malignancy. Now the second one, which is not so commonly seen these days, is a peptic stricture. So peptic stricture, you should also talk about, except that you immediately say that these symptoms are for just 3 months and the patient has lost about so much of weight. Therefore, I think peptic stricture is less likely. The same thing for pure motor disorders like an achalasia. In 3 months, you don't expect so much weight loss. So therefore, you can say that, given that the symptoms are only for 3 months and there's so much weight loss, I think that these 2 disorders are less likely. Never say no for a diagnosis because you never know, right? And Dr. Jayanthi has said that correctly. You say, and you just say, no, this is not the correct diagnosis. Examiner will think you already know the case. So always go and say this is very less likely or something like that. Okay?
Sure.
Okay, thanks, ma'am.
One important question that you should ask is, are you able to pinpoint with your finger where the food is getting stuck? That you should ask. Yeah. Why is it important?
If the patient is able to locate it, it might be due to functional.
No, Aravind?
No.
Aravind? If the patient points out to the upper chest or the lower chest, what does it indicate? You always should ask the question, very important. What does it indicate?
If it is an upper chest, then we can think about webs, ma'am. And if it is a lower chest, we can think of Shashi.
The patient locating it has any relevance to the real site of the disease? That's a question.
Location. That's a question.
The patient feels it is in the upper, patient feels it is in the lower. Does it have a real relationship to the site of disease in the esophagus?
So the answer is, in the upper third, it will pinpoint to the site, but in lower 2/3, it is always overlapping with the other. In the myotonic plexus, there's an overlap of the nerves. And therefore, when they point to the lower chest, it will not correlate with your endoscopic finding. But if they point out to the upper portion, upper third, invariably it will localize. So this question is asked. So therefore, in your questioning of the patient, you have to ask, are you able to localize where it is getting stuck? No harm. You can always ask the question. And once you say that, he localizes, there'll be a viva on that. So that we know the answer to that. Okay, very important. Okay, continue.
Yes,
okay, for completion's sake, what are the situations where you get food impaction? Food impaction. Where do they get it?
Condition, sir.
Yeah.
In Shatsky's ring, we
Is
can.
it that you eat a big banana and you get food impaction?
Shatsky ring, he said. Yeah, Shatsky ring was one.
Okay, Shatsky. Okay, Shatsky ring.
Two.
So, webs, sir.
So generally, it could be with a prior history of dysphagia or in the absence of dysphagia. So if the dysphagia is absent, generally it means that the narrowing is not that very significant. Okay. Perhaps the lumen is sufficiently wide enough to allow the normal passage of food. But the big bolus, which are the types of food which usually get stuck in the esophagus?
Meat, sir. Large
yeah,
bolus.
That's very simple. Smooth things which can be gulped down without much mastication. Okay. Some people know, like a big banana, they swallow like that. Meat is one thing which most people, these people with the dysphagia, probably they'll be denied this sort of food and they will also be crazy for all those things. They may gulp down big pieces. So gulping down a large piece without masticating, then gulping down a big piece of fruit. Then some people, of course, when they swallow spongy food also, they may develop this problem. Shobna ma'am, is there anything particular about the spongy food dysphagia?
So spongy foods like, idli or dokla, for some reason, I think what happens is when you don't chew it properly, they form a very dry bolus. And dry boluses are very difficult to swallow down. So even if you take, even if nobody has dysphagia, they take a large bolus of idli, it tends to kind of get stuck, at least in the mid-thorax, because of the tracheal and the bronchial impression. Second thing is EOE. EOE is very, in the young people, when there is food impaction, think about EOE. And of course, that there is a underlying stricture, not just Shatsky. Let's say a patient of CA esophagus, it's a very early CA esophagus, slightly large bolus is likely to cause food impaction. Okay, so food impaction may occur, it is more like an acute on chronic phenomenon.
Yeah, like mostly it is an acute on chronic, and very, very rarely only they don't have any symptoms. Okay. Okay, there was some question about one correction from the chat box. Can we directly mention as oropharyngeal dysphagia instead of nasal regurgitation or choking? So when you are summarizing, it is better to tell in patient's words rather than oropharyngeal dysphagia. Because if your diagnosis is oropharyngeal dysphagia, you cannot use that term because you lose the advantage of discussing it further. So you can say that there was no difficulty for initiating the act of swallowing, and its difficulties afterwards. So that will cover it without any nasal regurgitation or change in voice or tracheal aspiration. That in one breath you finish off the entire thing. Okay, so that means examiner is quite aware that you are trying to exclude oropharyngeal dysphagia. Okay.
What is the rate of transmission of food bolus after swallow? Jaswant, until it reaches the OG junction? What's the rate? What's the rate of esophageal peristalsis? All this you should know, no? That's why Dr. Shobna was mentioning, when if you take an idli and swallow, keep gulping, if the rate of emptying is not there, you will get a bolus impaction. So what is the rate of movement of the peristaltic waves in the esophagus? Arvind?
3 centimeters. 3 centimeters.
3 to 5 centimeters per second. Per second. You cannot just say 3 to 5 centimeters.
Second.
Okay, ma'am. We will allow Arjun to present his presentation so that let him present it. Arjun, please.
Am I audible, sir?
Yeah. You have to share your screen.
Yes, sir. Yes, sir. Is it visible now, sir?
Yeah, please. Just move it. Just show the slide.
Yes,
okay, start.
Good evening, all. So I'm Dr. Arjun. I'm going to discuss briefly about approach to dysphagia. So dysphagia is basically originating from a Greek term. So this means difficulty or disorder. Phagia means to eat. Now there is a subjective as well as an objective definitions which you can find in literature. Mostly subjective definition has been taken into practice. Now, subjectively, you can tell dysphagia is actually a sensory problem. It's a sensation of food hinted or sticking in its passage from the mouth to the stomach, or a perception of bolus lodged in the chest. Objectively, you can tell it is an abnormal delay in the transit of a liquid or solid bolus during the oropharyngeal or esophageal stages of swallowing. Now, there is, it need not always be the patient be telling us that he has a dysphagia or he has this sensation. He may come with some other symptoms. However, he may be definitely having dysphagia. At the same time, not always everyone who presents with dysphagia will have an abnormal delay in transit or liquid time. The symptoms may be more into dysphagia. However, objectively, it may not be relevant.
So, Arjun, just hold on. Arjun, just hold on. So, one important thing is in colloquial language, in Hindi, you say, aapko, khana kha sakte hain, then that again becomes wrong. In Tamil, we have, can you swallow? Now, swallow is different. So what you should ask is, after you swallow, is there a hold up of the food and you need water to push it down? That's very important. The English language of swallow is just transfer of the food from the oral cavity to the esophagus. So when you're asking a question, the patient will say, no, I have no difficulty in swallowing. So just be very careful in the language with which you speak, and ask one further question, that when you take the food bolus, does the food go down or you need water or liquid to push the food down? Very important in the history taking. Okay.
Yes. Yes.
Okay,
So
1 minute.
the,
1 minute.
yes.
They said the prevalence is 20%, which is 1 in 5.
Yes, ma'am. This is an US data which was published, ma'am. I was not able to find out in Indian data, ma'am.
No, I think
No, but this
Arjun
is,
has
I
to be
think this
careful.
must be
Yeah.
a specific group. This must be a
Okay.
specific group. It cannot be normals.
Yeah.
1 in 5.
Okay, ma'am.
Okay, let
So
him
just go
present
back
that.
to that reference and check, please.
Yes, ma'am. Sure, ma'am.
Okay, thank you.
Okay,
Yes,
Arjun, go ahead.
Again, US data which was published in 2019 suggested it affects 50% of people of age more than 60 years. And there are some literature stating that women are more affected as compared to men, and old people are more affected as compared to young people. Moving on to some basic, it is always important to understand the basics before going into dysphagia per se. So, as you all know, the food has to travel all the way from the oropharynx to the stomach. So, the adult esophagus is about 18 to 25 centimeter in length. There is a cervical as well as thoracic part. Harrison states about 2 centimeter anteroposterior luminal diameter and 3 centimeter lateral plane diameter for esophagus. And the critical diameter, as we have discussed earlier, is 13 millimeter, or as ma'am told, 2/3 of the lumen should be obstructed to cause dysphagia. There are 4 physiological constrictors as well. Now, swallowing, as per International Classification of Functioning Disability and Health, is basically a function of clearing
Let's
food.
go back to the slide. No, you don't be in a hurry. Don't try to finish off. Now, that is what is important. 2 centimeter anteroposterior and 3 centimeter lateral. Just
Yes.
see that
Which
it is
which are the constrictors?
Yeah.
Sir, upper esophageal sphincter, then there is a at 6 inch, and bronchoaortic constrictors at 9 and 11, and then the right thrust of diaphragm at 15 sir. Inches.
Okay.
6, 9, 11, and 15. Yes.
inches.
In centimeters, it is 14 to 16 centimeter. That is in the figure.
Okay, cricopharynx, the indentation by the bronchi, then diaphragm, then the cardiac
Yes.
sphincter. Okay.
Yes. Yes.
There could be indentation by the arch of aorta and the trachea. Okay.
Broncho. Yes.
Okay,
Shall I move
go ahead.
forward?
Go ahead.
So, so as I mentioned, swallowing is a complex and a coordinated process. So most of the time, swallowing helps us in nutrition, which we take it for granted, and it's an effortless process. There is also a subconscious swallowing process that is happening at least once per minute, which acts as a housekeeping mechanism. And there is something called as reflex pharyngeal swallowing as well, that actually acts as an airway protective mechanism, where every cough is followed by an episode of swallowing. So, moving on to the phases of swallowing, it is important to know what are the phases of swallowing also. So there is an oral phase is divided into oral preparatory phase as well as an oral propulsive phase. The pharyngeal phase involves there is an esophageal closure, airway protection, there is elevation of the hyoidal complex, and then bolus transport across the upper esophageal sphincter. Then comes the esophageal phase, which is predominantly with the help of peristaltic movements. So the oral preparatory phase is actually the initial phase where there is coordinated of the lips, jaw, buccal, as well as the facial muscle, along with the tongue and soft palate, and it helps to break down the food and mixing it with saliva. Now, once this is done, the oral transverse phase comes up. Now, here there is upward as well as backward movement of tongue against the palate, which leads to the propulsion of food bolus into the pharynx. And then comes the pharyngeal phase, when there is the movement of the tongue, pharynx, which prevents the reflux of food into the nose and larynx. And then there is propulsion of the food bolus into the esophagus. Now, all these phases happens within the period of 1 second. Then comes the esophageal phase, when there is coordinated peristalsis of esophageal body with simultaneous relaxation of lower esophageal sphincters, which takes about 7 to 15 or in an average 10 seconds. So this is the phases of swallowing which we should always be remembering. It helps us in the history taking as well. We have to ask the patient when does he feel the discomfort at the maximum? Is it in the first second after or just after initiation of the swallowing process or after seconds of swallowing? Now, it is also important that we should know what is the neural control of swallowing. So, the peripheral stimuli from the oropharynx, larynx, and the esophagus through the sensory neurons involving the fifth nerve, seventh nerve, ninth, and the 10th nerve reaches the cortical and subcortical structures as well as the dorsal swallowing group in the brainstem. Now, from here, there is always an interaction between the dorsal swallowing group as well as the cortical and subcortical structures. And the stimuli is given out to the ventral swallowing group, again in the brainstem center. From there, to oropharyngeal side and the esophageal state, there is a separate group of nuclei present. So the oropharyngeal nuclei consists of the triangle, facial, nucleus ambiguous, hypoglossal, and C1, C2. The esophageal part has a dorsal motor nucleus. Then from this nucleus to the motor, through the motor neurons, it reaches the oropharyngeal as well as the esophageal part respectively through nerves of 5, 7, 9, 11, and 12, along with ansa cervicalis to the oropharyngeal part and vagus mediated to the esophageal part, causing primary peristalsis. Now, any of the dysfunction of swallowing mechanism or peristaltic contraction of the esophagus? Yes, ma'am.
Can you just tell what is primary peristalsis, secondary peristalsis, and tertiary peristalsis?
Ma'am, primary peristalsis is the normal physiological peristalsis that happens once the food is swallowed. Secondary peristalsis happen once there is a dilatation of the esophagus at any point, any part of the esophagus. Tertiary is basically
no. What is secondary peristalsis? Secondary peristalsis is clearance of whatever residual is there in the esophagus.
Okay.
Yeah. You must know what is primary, secondary, and tertiary. So
Okay.
primary is, it is initiated through the CNS, no? That is the primary
Yes,
peristalsis is a forward movement. Always there
Yes.
will be some residue that is there with the esophageal lumen, and that is cleared by the secondary peristalsis. And tertiary are non-peristaltic contractile waves, which
Contractions in the
just
esophagus.
moves, yeah. So you
I think primary and secondary are part of the swallowing process.
yeah, but they must know what is
Okay.
secondary. Secondary
Yeah,
is clear.
tertiary is not part of the swallowing process. It can come independent of swallowing process.
So just a quick one. The term tertiary peristalsis is something that is appreciated only on barium, and therefore it has been removed from the physiology. It's
Yes,
not
correct.
actually seen on manometry. You never see tertiary peristalsis. So therefore, that term is no longer there in many physiology textbooks.
Okay.
So, ma'am, ask a doubt. So, should we not use that term anymore?
Yeah, so
I have stopped using it, but
Yeah.
I don't think it's there in Slisinger also now. Is
yeah,
it there?
earlier we had that, but it is called as non-propulsive, non-contractile. You know, it is
Yes.
something which is non-propulsive and is non-contractile. So therefore, it doesn't come in the phase of swallow. But you
Yes.
must know that there was at least something like tertiary, but primary
Yeah,
and secondary is very important.
Correct, but it's no longer there in the routine things. But as long as they know that it is something that used to be there, that's fine.
Yeah,
Because
yeah,
now we don't use that term anymore.
yeah. And what is TLESR?
TLESR.
What is TLESR?
Transient lower esophageal sphincter relaxation, ma'am.
What is it?
Burping, ma'am, actually. That happens with
Burping.
Is it physiological or pathological?
physiological. That is physiological.
Okay.
The release of fundic gas into the
No.
esophagus.
But we are talking of physiology. In physiology, what is TLESR? We are not talking of disease states. So normally, can you have? So what happens in
yes,
GR
ma'am.
and what is in health? How many you can get in a minute? How many TLSRs? Is it normal physiological? You can get a transient low esophageal sphincter relaxation. Okay, it occurs, I think, 1 to 2 per swallow. But then in patient with GRD, they have more frequent TLSR. So it's one of the causes of reflux. And that's when the acid pocket, the alginates act and reduce the TLSRs. All this you should know. The basics, be very strong on that.
Okay, Arjun.
Yes, sir. So, in order for dysphagia to happen, there should be a dysfunction in the swallowing mechanism or the peristaltic contraction of the esophagus, which can be predominantly a mechanical or a structural problem, or can be a motility or a neuromuscular problem. Now, specifically, there are some risk factors that has been explained in literature. For example, some are aging, dementia, stroke, smoking, obesity, pregnancy, hyperthermia, alcohol intake, scleroderma, medications, corrosives, radiation injury, esophageal surgery, or dryness of mouth. So it is always important to ask or look for these risk factors during our history taking so that we can get a diagnostic clue in these factors. Now, there's something else also. Now, older adults has a generally lower amplitude of primary and secondary peristaltic activity. They have a poor distendability of esophagus, and they may have some abnormal sensory perception, which may lead to dysphagia, production of dysphagia in this kind of population. In the event of a structural narrowing, the symptoms may actually vary depending upon the luminal obstruction and the type of food that is ingested. And minimal obstructing lesions may cause only dysphagia with only a large poorly chewed boluses. And GERD, as we have discussed earlier, GERD can produce dysphagia due to peptic strictures. It may also produce dysphagia in the absence of peptic strictures, as well as what has been told in literature. Now, when you get a patient with dysphagia, what should be our primary aim? So we should first try to figure out whether it's true dysphagia. Try to localize where is the site, which we have discussed earlier. See whether it is structural or motility related problem. Now, true dysphagia has to be differentiated from globus because globus happens in between the meals, won't be related to the meals as well. Site, as we have discussed earlier, you can ask where exactly the patient feels about the dysphagia. Is it above the sternum or retrosternally is he feeling the problem? And then with further history, we have to figure out whether it's a structural or motility disorder, which we discuss later. Now, there can be a scenario to us that when the patient actually denies dysphagia, they will tell this, I don't feel dysphagia. I mean, I don't feel any issue with my swallowing or not, as madam has pointed out already. In this scenario, we can use some leading questions to either to the patient or the bystander who has come with him. So you can ask him whether he is eating slowly as compared to others. Is he the last to finish his meal? Does he tries to avoid problematic food by himself? Does he follows a very careful diet, as this happened recently? Does he drinks liquid with every bite of meal? Does he regurgitate to clear his bolus? And does he have any posterior throat sensation or discomfort by so on? So this can actually point out to dysphagia, which patient may not actually tell us. However, with history, we can actually get out that patient actually has some kind of dysphagia. Now, dysphagia can be grossly divided into oropharyngeal and esophageal. Oropharyngeal dysphagia is also called as transfer dysphagia, which actually consists of issues with pharynx and upper esophageal and associated structures. Usually, neuromuscular abnormalities are more common. There can be rhinophagia, which may not be associated depending upon the inflammation which is present or not. Esophageal dysphagia, on the other hand, involves the body, lower esophageal sphincter, and sometimes a gastric fundus as well. It can be mechanical or a motility-related disorder, which we will be discussing later. On to oropharyngeal dysphagia. Here, the disturbance may be either in the transfer or the airway protective functions of the oropharynx. It can be a motor problem. It can be a problem related to the airway closure. It can be a problem with relaxation or opening. It can be a sensory problem or with the problem with coordination. It is more prevalent in elderly population. The symptoms usually occur within the initial seconds of swallowing because the whole process of oral and pharyngeal phase happens within the first second after swallowing. And as I told earlier, neurological may be slightly higher, more seen as compared to muscular and anatomical issues. What are the causes of oropharyngeal dysphagia? Now, the list is endless, but I tried to segregate it into three categories. Anatomical causes may be there. For example, which we have discussed is Senger's diverticulum, tumor, enlarged thyroid gland, osteophytes, head and neck surgeries, esophageal webs, abscess, very importantly, cold abscess. Neurological causes such as cerebrovascular accident, post-polio syndrome, radiation injury, Parkinsonism, head and neck surgeries, multiple sclerosis, CNS tumor, botulism, supranuclear myotonic dystrophies, ALS, and muscular issues such as polymyositis, myasthenia, muscular dystrophy, radiation injury, thyroid diseases, and head and neck surgeries. There can also be some drugs that has been shown implicated in oropharyngeal dysphagia. So there are some centrally acting drugs such as phenothiazines, metoclopramide, benzodiazepines, antihistamines, neuromuscular junction acting drugs such as botulinum toxin, procainamide, penicillamine, erythromycin, aminoglycosides. Drugs that can cause muscle toxicity like amiodarone, alcohol, HMG-CoA reductase inhibitors, cyclosporin, penicillamines, and anti-sialagogues such as anticholinergics, antidepressants, antipsychotics, anti-Parkinson's drugs, antihypertensives, and some diuretics, and then digoxin, vincristine, and trichloroetrin kind of drugs have been implicated in dysphagia. However, it has to be checked further. Now, any problem in the proximal esophageal or a pathology in the proximal esophageal pathology can also cause some symptoms which can mimic oropharyngeal dysphagia. Here, mostly it's an obstructive problem due to proximal rings, Plummer-Vinson syndrome, or a proximal stricture, benign, which can be benign as well as malignant. So this thing also has to be kept in mind so that the symptoms may sometimes appear proximal to the actual site of etiology, as Madam has earlier pointed out. Now, when you get a patient with oropharyngeal dysphagia, what are the main symptoms which we would want to look at? So, we can ask the patient whether he has a difficulty or delay in initiating the swallow, whether the patient has any esophageal regurgitation while swallowing, is there any history of aspiration? Does the patient request repetitive swallowing to achieve the clearance, or is there any cough during swallowing, also called as deglutitive coughing? If you ask, the first three has to be the most important symptoms which you should be looking at. Along with this, we have to look at the associated symptoms depending upon the etiology. Now, patient may have associated nasal intonation, drooling of saliva, dysarthria, diplopia, dysphonia, muscle twitch or fasciculation, progressive weakness, fatigability, drooping of eyelids with activity, focal neurological deficits, and sensation of food residue in the pharynx, which can be because of neurological aspiration or even senkers. Most of the symptoms are pertaining to the specific cranial nerve involvement that can cause dysphagia. They can also have decreased saliva, poor mastication, difficulty to hold the food in the oral cavity, frequent throat clearing, weight loss, which we are discussing in this case, halitosis, especially in singers, and distal esophageal issues with stasis, and recurrent pneumonia. So this may associated symptoms.
Sometimes the faces, as you see the faces, you can put a direct question, okay? Parkinsonism, for instance, scleroderma. The faces itself will give you a clue as to the possibility. If the patient comes with constipation, then you have to give a lead question for dysphagia. So most of the Parkinsonisms and all, you can almost pinpoint and say that it's likely to be neurological. Okay, the drooling of saliva and all that. Okay.
Yes. Thank you. Now, on to esophageal dysphagia. It's also called as transit dysphagia. Now, basically, it's a defect in the transfer of bolus from the esophagus right to the stomach. It's mostly seen it can be seen both in elderly and young based on the etiology of the problem, and it could be either structural or motility related. Now, there is a wide range of esophageal causes for esophageal dysphagia. We can divide it either into motility disorders and mechanical disorders. Now, motility disorders, as we all know, can be primary or secondary. Primary motility disorders, the most important ones are the achalasia cardia, distal esophageal spasm, hypercontractile esophagus, hypertensive lower esophageal sphincter, causing gastric junction outlet obstruction, or any other peristaltic abnormalities. Secondary motility disorders include Chagas disease, reflux-related dysmotility, systemic sclerosis, and other rheumatological disorders, and even medications that can cause esophagitis. Mechanical disorders can be divided into
and fundic lesions in the fundus. No, fundic or pseudoachalasia will also present as dysphagia. Pseudoachalasia.
Yes. Thank you.
Paraneoplastic manifestations as small cell carcinoma of the lung. Then you have melanomas. Then celiac disease is known to cause dysphagia. These are all they'll all come as motor disorders, but unrelated. They all present as dysphagia, but they do not have any mechanical cause, but their motility disorders have been described. So pseudoachalasia, secondary achalasia, all these will come as a DD for the motility.
Okay, one more thing. You just mentioned medication. Now, the medications that you have listed cause motor disorders, not esophagitis.
Yes, ma'am.
The medications that are listed
here, yes.
All these can cause motor dysphagia.
Yes, ma'am.
Calcium channel blockers, nitrates, phosphodiesterase inhibitors, which the urologists use. All these will cause motor dysphagia. Opioids, in fact, you have to be very careful. When patients are on opioids, sometimes you will think that they can even present like achalasia, and the manometry can look like achalasia. So all these can cause minor motility disorders, and don't call it esophagitis. Esophagitis is a different set of disorders. Okay.
Yes. Thank you. The mechanical disorders can be intrinsic and extrinsic. Intrinsic involving carcinoma, benign tumors, diverticulum, esophilic esophagitis, peptic strictures, esophageal rings and webs, Schatzki's ring, foreign body, pill-induced strictures, and strictures related to tracheoesophageal fistula, which we had discussed earlier. Extrinsic causes also has to be kept in mind, specifically mediastinal mass, spinal osteophyte, a cold abscess coming from behind, and a vascular compression. All this has to be kept in mind when you are thinking about a mechanical disorder causing esophageal dysphagia. Now, here the symptoms are comparatively less as compared to the oropharyngeal side. So, patient may have heartburns, which can be continuous or can be occasional. Now, they can have chest pain, which can mimic an acute coronary event, especially in motility disorders. And they can have regurgitation of undigested or partially digested food, which is usually never served because they don't cross the esophageal junction. And they may have nocturnal episodes, and they may vomiting or retching these symptoms. Sometimes the patient will just tell there is a sticky sensation of bolus retrosternally, or there is something, the food is hanging up behind my sternum, or the food lump is caught at the epigastrium. So this kind of history from the patient can actually help us roughly about 60 to 70% to localize it correctly. 10% we end up localizing the problem proximally, and in 20%, as ma'am has told, we may not be able to localize it proximally, localize it anywhere. So it is always important to ask where exactly the patient feels the symptoms for. And always ask for weight, which can be associated with mechanical causes of dysphagia, and look for respiratory symptoms or odynophagia, which can also be there along with respiratory dysphagias. Now, when you're looking at history, you should always ask for the complications that can actually arise from dysphagia. Now, ask the patient whether he has sore throat, whether he has a wheeze, is there a recurrent chest infection in the past, whether he has got a chest pain, there's got recent change in voice, weight loss, as I mentioned earlier, or if he's dehydrated or not. Now, in this history, when you're going for taking a detailed history of this patient after them explaining their symptoms, always see what is the onset of the symptom. Is it a sudden or a slow onset? Is it there with dysphagia present with every meal? Is it a progressive problem or a non-progressive problem? Is it a painful problem or a painless problem? Does the patient choke eating? Importantly, ask whether dysphagia is good. See whether the symptoms appear with specific food. See if there is any history of atopy. Ask the patient whether he takes opioids for any other reasons, and look for the risk factors which we have discussed earlier. So these are the main history points which we would want to focus on to find out or to localize what the kind of problem is. Now, since we had discussed earlier, we have to differentiate between motor as well as mechanical dysphagia. Now, mechanical dysphagia can have a gradual or a sudden onset. Motor disorder is always a gradual onset. The progression is also often there in mechanical disorder. Motor disorder may not progress that badly, but then it can also happen. The type of bolus in mechanical disorder, patient will have dysphagia to solids unless it's a very high grade obstruction. Motor disorder will have dysphagia to solids as well as liquids. Response to bolus, often the patient will have to regurgitate the food or ends up regurgitating the food. The motor disorders, usually it may pass with repeated swallowing and drinking liquids in the early stages. And mechanical disorder is not temperature dependent. As we have discussed earlier, motor disorder can have some symptom relief with warm liquids. It may get worse with cold liquids. And with maneuvers, specific maneuvers, motor disorder may benefit, but not always in the mechanical disorder. And weight loss, if it is present, always in favor of a mechanical disorder, but again, we have to take it with a pinch of salt. This is an algorithm, although no algorithm will be enough or will be able to suffice us to reach a diagnosis. This is taken from recent review article from Lancet. So when you get a patient with oropharyngeal dysphagia, look whether the patient has symptoms with solids or the patient has got symptoms with solids and liquids. Now, say if the patient has got symptoms with solids, you can think in terms of a structural problem. Now, next, ask the patient whether he has got a progressive problem or an intermittent problem. Now, progressive problem, if he has, ask whether it's a slowly progressive problem, does he have chronic heartburn associated? And if not, ask whether it's a rapid progressive or if associated weight loss is there. If it is a slowly progressive chronic heartburn related problem, always think in terms of esophagitis or strictures. If it is rapidly progressive and is associated with weight loss, always keep in mind malignancy before going into investigating. If it is an intermittent issue with symptoms with solids only and likely to be a structural problem, then you should always consider a possibility of ring web, even esophagitis. Now, say the patient is telling symptoms which is both to like solids as well as liquids. We may think in terms of a dysmotility problem. Again, we have to go and ask whether the patient has got a progressive problem or an intermittent problem. If it is a progressive problem, and if he's got chronic heartburns, think in terms of scleroderma or absent contractility. If the patient has got regurgitation symptoms along with this, instead of chronic heartburn, think in terms of atlesia. If the patient has got intermittent symptoms and he has got severe chest pain, sometimes mimicking the acute coronary event, always think about distal esophageal spasm. Now, there can be an overlap of symptoms in all these diagnoses. However, this is just a algorithm to help us to reach a professional diagnosis. It is also important in a clinical setting to know what now can cause acute dysphagia. Now, always think about ask the patient about recent medication, look into a foreign body injection, look into a cerebrovascular accident. Tetanus can cause acute dysphagia. Any recent intervention, as we have discussed earlier, like physiotherapy, UL, and dilatation. Any inflammation or infection could be suspect. Candida, HSV, eosinophilic esophagitis should be suspected. Radiation injury is possible. Corrosive injection is also possible. So this can present as acute dysphagia to us. Now, once we are finished with our history, we can go in terms of physical examination. What are the specific things which we are supposed to look into in a patient? So most of the things which we had covered earlier in the case discussion has been just put out. So always look at neurological deficit, do a detailed cranial examination, look for other system examination to look for complications, neck nail examination, spine examination, oral cavity examination, look for signs of malnutrition. And it is always better if we ask the patient to swallow in front of us, ask the patient to swallow liquid, ask the patient to swallow solids in front of us. Look at the number of sips, number of bites, and the post-deglutitive clearing, if any, in these patients, which can actually give us a very good view of the patient's problems. Now, we have discussed sites classification of grading of dysphagia.
Just to interpret for a moment, I think you made a very valid point. Ask the patient to swallow in front of you. If the only time when you don't do this is if the patient is having obvious aspiration. Secondly, if the patient has, try and see whether he's making any maneuvers, not just how many swallows he's taking and all that. This is more useful for neurological dysphagia.
Yes.
Okay. So you can see what the patient is doing. You can actually evaluate properly. And then you can see whether he can take solids, liquids, making any maneuvers, pushing up his hands. All that you can see whether he's doing it properly. However, please avoid doing it. I want to reiterate this again. If the patient has a history of aspiration, please do not do this except when you have proper, facilities to suction and all that immediately. Okay, you can get into trouble.
Yes. Okay. Thank you. Now, grading, which we had discussed earlier. So there is grading from 0 to 4. Grade 0 is there is no dysphagia. Grade 1 dysphagia to solids. Grade 2 dysphagia to soft solids. Grade 3 dysphagia to solids as well as liquids. Grade 4 patient cannot even swallow saliva. There is also another set of grading by Takita that has divided into 6 grades. That is grade 1, patient complains of dysphagia and eats normally. Grade 2 requires requires liquids along with meals. Grade 3, the patient is able to take semi-solids but unable to take solids. Grade 4, the patient is able to take liquids only. Grade 5, the patient is unable to take liquids, however can swallow saliva. Grade 6, the patient is unable to swallow saliva. Now, when we are finished with our history and physical examination, we may have to know how to go forward with the workup part. Now, I'll just go briefly on the workup.
What about the examination of the systemic?
We would want to look at a detailed neurological examination and cranial examination is required in all patients with definitely suspect.
What are the important things you look in the abdomen as a gastroenterologist in dysphagia? What are the things that you look for? One is oral cavity, you mentioned then?
Yes, ma'am. We can look at any mass probably in the G junction mass that can come up. So,
well, very often G junction mass is not palpable.
Lymph nodes
you have to examine, you have to look for lymph nodes on either side, not left alone.
Yes.
Okay.
Yes,
the lymph
and
nodes.
spine examination.
BT, I think we should not discuss. See, once you present the examination, it's easy to discuss, no? Otherwise,
Yes.
yeah, so you have to look for anemia, you look for extra
Yes.
intestinal manifestation, cutaneous markers of internal malignancy. Then in
Okay.
the chest, you have to look for widening of the mediastinum, you have to look for trough space dullness, you have to do a Middleton sign to pick up any fundic growth, and you have to
Yes.
auscultate the chest for pneumonia or Krebs. All these are very, very important. You have to mention the oral cavity movement of the soft palate, movement of the uvula,
Yes.
movement of the posterior pharynx. Everything has to be mentioned. It is not an easy case for examination.
Yes.
Everything has tylosis, then all the other findings you have to mention. Okay.
Sure. Thank you.
But
Yes. So the workup.
I don't think we should proceed, beyond this. The
Yes.
workup and all, I think we should ask the candidate and then only, no point.
no,
in-
just for completion's sake, let him finish, ma'am.
Okay.
So I just briefly
Okay, you
go
can
through the
finish it
workup.
first. Yeah.
Yes, yes, ma'am. So it's a multidisciplinary approach. Often we need a help from the ENT specialist or a neurologist. So as a gastroenterologist, we have an option of video fluoroscopy, which is considered to be a gold standard for oropharyngeal dysphagia, also called as modified barium swallow. You can do an upper GI endoscopy. There is an option of fiber optic endoscopic evaluation of swallowing, which is actually a modification of OGD. Nasopharyngeal endoscopic method can be used here. There is a high resolution manometer that is available to us. Automated impedance manometer is basically a modification to the high resolution manometer where impedance measurement is also taken into concern. And a bedside test such as water swallow test may be tried, but however, as Shobna ma'am has told, always see if the patient has an history of aspiration, better not to try this. And a decision between endoscopy and fluoroscopy has to be taken. Now, where the patient has aspiration, it is always better to do endoscopy along with fluoroscopy. If the patient has got residual symptoms of residue, you do an endoscopy and fluoroscopy. If the problem is with biomechanics, always do fluoroscopy. Or if the problem is with upper esophageal sphincter opening, you do a fluoroscopy. And for bedside evaluation, endoscopy may be a better option. And esophageal dysphagia, on the other hand, apart from the normal investigation which we do, we have the option of barium swallow or timed esophageal. You can do an upper GI endoscopy along with endoscopic ultrasound so that you can look at the mediastinal structures as well. You can take a biopsy if it's suspecting esophageal eosinophilic esophagitis or a CA. You can use the help of high resolution manometry, and something new that has come is endofluid, that is endoluminal function lumen imaging probe, which helps us to find the distendability of these areas. So ideally, we need a combination of this test. None of this test is as a single test is really good to find out or get to us in the diagnosis. So if you look at barium swallow with endoscopy, it is basically a complementary test. Both are complementary tests. They cannot be duplicated, and it helps. The decision between these has to be based on what is the most likely diagnosis in specific section of patients, depending upon the history. And for better anatomical understanding and therapeutic window, as definitely OGD will be a better option. If you're looking at motility etiology or oropharyngeal dysphagia, barium esophageography is a better option. And if you're looking at strictures, barium studies are found to be more sensitive in strictures. There's a picture about mid-esophageal stricture, that is figure A, and Lisie in figure B. This is barium swallow. High resolution manometry, as I have told, it is basically an adaptation of the conventional esophageal manometry that was there. So they got, along with impedance being included, there's got a better accuracy in visualization to find out the pressure. This is the cross plot that has been kept towards your right. And this is a brief summary of the approach to patient with esophageal dysphagia. So whenever you get a patient with esophageal dysphagia, you look at the history of prior radiation, caustic injury, surgery, or carcinoma. Always better to do an upper GI endoscopy. If there is the decision between barium swallow and OGD is a bit controversial in multiple cases. So if there is no structural abnormality in upper GI endoscopy, you can go do a barium swallow if you're thinking about a dysphagia that is predominantly to solids alone. That is, you're thinking of a mechanical problem. If you're thinking about a motility related problem, you can go forward doing an esophageal manometry. Now, esophageal manometry sometimes can give us a diagnosis. Sometimes you can get equivocal results where we have to do repeated manometry after, say, 1 or 2 weeks. And if it is normal, you have to widen your evaluation and go for other causes also.
Okay, that's the end of your slide, no, Arjun?
Yes, yes, yes.
Thank you. It was a wonderful presentation, and I want to congratulate you for making it such an elaborate presentation. It's good. And please stop sharing. I want to finish off the
Yes,
case.
sir. Sure, sir.
No, not this.
Yes.
I want to finish on the previous case. Okay. So everyone has heard about how to do. Now we will discuss the remaining slides. So in the physical examination part, there was nothing much on that our previous patient. Apart, his BMI was very low. Oral cavity was normal. Stomach examination, I think Prof price was assigned. There was a question as to how to find out the fundic tumor. You mentioned some sign. Is it the dullness of the Prof price?
It is Middleton sign that you make the patient sit up and you hook your finger under the left rib cage, and if there's a mass, sometimes the mass can be felt in the upright position.
Can you put it the spelling in the chat box, ma'am, for the benefit of all?
Middleton. Middleton.
Okay.
Middleton.
So physical examination, other system, everything was normal. So on physical examination, this particular patient, apart from the low BMI, I think we did not get much positive findings. And the patient's hemoglobin was 10. Okay. Other tests were normal. This is the endoscopy finding. Growth extending from 37 to 40 centimeters. And biopsy actually shown the adenocarcinoma. Okay, now the question, how do you assess, Arjun, how do you assess the extent of the lesion? Which are the situation when you want to really assess the extent of the lesion? Is it important?
Yes, sir. In this case, I would want to look whether there is any local regional spread, because for therapeutic purpose, it is always important
No,
to
what I
make the
meant
TNM.
is actually not only the horizontal extent and the longitudinal extent.
Yes,
Because
sir.
longitudinal extent we use it for certain purposes, and horizontal extent and look for metastasis for assessing the prognosis and deciding the management. No.
Yes.
So suppose you have a growth and
So,
a scope, you are not able to pass the scope down. You know the growth is at 25 centimeters. Do you really want to know the extent of the lesion? Others, Jaswant,
surgical.
Aravind.
Yes, sir. Because based on that, we can plan the surgery, sir.
Okay, we should
to
know
ask to
the
what
length
type
of the
of surgery.
lesion to plan the treatment, whether it is curative or palliative form. Okay, so what are the methods by which we can assess the longitudinal extent of the lesion? One is by endoscopy, if the scope can be passed through the lesion. If the scope cannot be passed through the lesion, what are the options?
CT, sir.
CT neck and chest.
Yeah, CT.
CT thorax and CT thorax of abdomen and thorax
neck,
with contrast. With IV contrast.
Neck to be included. Neck.
Neck.
Yeah.
Yes,
so
yes.
We have to assess the extent. So which are apart from curative intent, is there any other indication to know the exact extent?
See what classification you should know, no?
Because in the palliation, if you are planning to put a stent,
Yes.
you should know the length of the stricture, no? Then only you can plan the length of, then decide on the length of the stent. Some people, if there is, some people try to dilate and pass the scope down, as probably was done in this case, and try to see the lesion slow down. If that is not possible, a CT, good CT will help us to find out the longitudinal extent and whether the lesion extends into the stomach, and also help us to find the horizontal extent, and also for the staging of the disease to plan out the further treatment. Shobna ma'am, any comments?
And dilatation for placing a rice tube for feeding. If you really want to build up the nutritional status of the patient, so that's why you always keep a rice tube ready when the scope is not passing through, dilate it and place a rice tube for feeding purposes.
Shobna
So
ma'am,
sometimes with the, yeah, so yes, I'm very much there. So quick comments, one or two things is, the usual question that the examiner asks is, what will you first, an endoscopy or a barium? And if you are an endoscopist, it's always better to say, yes, I can do endoscopy except in situations where I'm suspecting a Zenker's diverticulum or, the indications for barium now are very limited. Neurological dysphagia. Second is if you want to see for the extent of the lesion, like you just mentioned in malignancy or a corrosive, you want to know the length of the stricture. Then in that case, you would do a barium or a CT scan. And thirdly, with the advent of pediatric scopes, you should not be talking about putting adult scopes, putting a Ryle's tube and through the mouth and withdrawing it from the nose. No, you can directly say that I'll put a pediatric scope through the nose. And then you can directly put the Ryle's tube through that guide wire. It's so much more convenient. So that is one of the things that if the adult scope is not going through, just say that, yes, I can use a pediatric scope. Why should you push for dilatation? You can take a pediatric scope, go in and see the length of the lesion.
You should also know the lymphatic drainage, okay? Lymphatic drainage of the esophagus.
Yes, that they should know because that is extremely important, not only from the diagnostic, but also from the management point of view.
I think
So,
lymphatics are very important because this is often asked in the examination. Lymphatics. I will just show you. Lymphatics is very, very important because in all cases of CA esophagus, this question will ask. So one should know the lymphatic drainage of the esophagus. Which actually, there is a peculiar drainage of the esophagus because along the submucosal plexus, the lymphatics can go from the lower to upper, from upper to lower, and the lymphatics of the esophagus can go to the upper abdominal lymph nodes also. Okay, so you should learn it thoroughly. You should learn it thoroughly, and questions will come both in the clinics as well as in the practical examination. So you have this particular journal where you have the details. Cancer Management Research 2018. You have the details. Anatomy of lymphatic drainage of the esophagus and lymph node metastasis. Okay. Okay, I think we had a wonderful discussion.
Yeah, this viva is often asked. Growth in the upper third, but celiac nodes are
affected.
Seen on the CT scan enlarged. So what stage of the disease it is? It's a viva that has been asked by many of the examiners. Or you have a lower third growth and there's left supraclavicular lymph node. So you should know the lymphatic drainage. You must know what is the spread and the staging based on the site of growth. Upper third with nodes in the abdomen, lower thirds with nodes in the even right cervical. You have a double thoracic duct, then you can get even in the right cervical. So right cervical nodes, left cervical nodes, all those things are very important in the esophagus, okay? And of course, you must know that there's no serosa in the esophagus. So the spread is rapid. So I think as we go along with the cases, I think you'll be able to understand better.
So 80%, I think it's the corresponding lymph nodes, but 20% actually can be anywhere. That's the route. So even upper esophageal can go to the celiac lymph nodes. So that is the risk. Okay.
And it's advanced. It's advanced malignancy.
Okay. I think it was a very good discussion, and I congratulate the presenter for having done a great job. And now it's time to say a vote of thanks. I invite Dr. Hari, who is the new coordinator. Please, Dr. Hari.
Jaswant and Aravind, you did a good job. Good.
Thank you.
Yeah, good job today.
Thank you.
It was a good discussion.
All the presenter as well as the discussion, all of them done wonderfully well. As a starting, this is fantastic, and I think keep up the good work. I think we were also not in the clinics mode; we were in the teaching mode. You would have found out the difference. And when on topics are discussed, will be mostly on the teaching mode. Okay, Hari, please for the formal vote of thanks.
Very good evening. That was a very informative session that we had today on dysphagia. From the side of the residents, I would like to thank our guest faculty, Professor Shobna Bhatia ma'am, moderators, Professor Jayanthi ma'am and Professor Varghese sir for their guidance during the presentation. I would also like to extend our gratitude to our ISG Kerala office bearers, President Dr. Roje Mukada sir and Secretary Dr. Anthony Chatapura sir for providing such a platform for an academic session like this. I would also like to thank our presenter, Dr. Arjun Gupta from Lisie Hospital and Discussants, Dr. Jaswant and Aravind from Global Hospital Chennai for volunteering for the discussion today. And also like to thank all the attendees for attending the session today. Thank you all. It's a wonderful session today.
Good night.
There's someone who's blocking. I'm not able to send messages. No, Adib Aslam is not in this meeting. So it's not allowing me to answer the questions. That's why I could not. I've answered here, but it's not getting. So just check on that.
No, what when you chat, you put to everyone. Probably you would
No,
ask.
I put that as everyone. I was typing. Only thing is coming as Adib Islam is not available. It's not in this meeting. Okay, no problem.
There are 3 questions, ma'am.
Okay, no
Repeat. Middleton is the one we are. Yeah. When is PG indicated, ma'am, for nutrition? Peg.
Or that we'll discuss as a case, no? Let's not
Yeah,
discuss now.
okay. So I think we have said what to thank, so no more discussion. So
Thank
good
you,
night
yeah.
to all of you until we
night.
meet next time. Okay.
Good night,
Yes.
Shobna.
Thank you,
Bye-bye.
sir.
Thanks,
Shobna
Jayanthi.
ma'am,
Thanks,
thanks
Preeti.
for joining us.
Thanks, Preeti.
Thanks. I couldn't put
It's
on my
wonderful.
video for other reasons. I'll talk to you all later. Okay.
Okay.
Thank
Bye.
you. Bye.
Bye. Good
Bye.
night.
See you. Bye.